Hey, welcome everybody. We're so glad you're here. Today, I'm excited because we have a special guest who's going to help us learn a little bit more about navigating our health insurance options as open enrollment season approaches for many of us. Samantha Arceneaux is a board member at Touch by Type 1, an organization that is doing really great things in the type 1 space. She's also a mom to a daughter with type 1 diabetes, but I'll let her tell you a little bit more about herself when she gets into her presentation. Real quick, my name is Scott Johnson. I'm a senior manager of community here at Blue Circle Health. I've lived with type 1 diabetes for 45 years, and I just really appreciate you allowing me the honor and privilege of hosting today. Now, before we get started, I also want to plug Touch by Type 1's free annual conference happening this Saturday, September 20th in Orlando. I'll share a link to their website in the chat so you can check it out if you happen to be nearby Orlando or can get yourself to Orlando. There's over 1,000 people registered so far, which is amazing. So we're all excited about that. And Blue Circle Health is going to be speaking. We've got a couple of our folks, Zailu and Xanadu, speaking on the Spanish track, and then we'll have a booth there as well. So stop by and say hi if you're nearby. In terms of an agenda, we've got a great presentation that Samantha will guide us through. And as you can imagine, there's a lot to cover with a topic like this. So we'll do our best to get through everything. But even with that, you'll need to let us know if you'd like us to go into more detail on anything. Now, before we get going too far, I need to cover some quick housekeeping items. We welcome and encourage you to use the chat feature along the way. I'll keep an eye on it throughout the session if you need anything while Samantha's presenting. And we're happy to take questions, but we are going to hold them until the end so that we can be sure Samantha has enough time to get through her presentation. So if you do have questions, go ahead and add them into the chat or use the QA feature, and we'll do our best to get to as many as possible. A couple more things I have to mention. This session is being recorded. Participation in this event is completely voluntary and may reveal your identity and any identifying information that you share with other participants. For example, comments in the chat and during discussions. Finally, we're not providing medical advice, individual or otherwise, and we may refer you back to your healthcare team for detailed and individualized care. And then finally, and this is the last thing I promise, for anyone who is not familiar with Blue Circle Health, stick around until the end. And after Samantha's done, I'll run through a very brief overview and answer any questions about Blue Circle Health that you may have. So, all right, I know that was a lot. Thanks for your patience with me. Let's go ahead and get started. So, Samantha, I'm going to put your slides up on the screen and the show is all yours.
Perfect. Thank you so much, Scott. As you said, my name is Samantha Arceneaux. I'm one of the board of directors for Touch by Type 1. I have been a mom of a Type 1 for over 12 years. She was diagnosed at 22 months old. And my former life, as you could say, is actually in the medical field, which is managing a private practice. So that's where I learned how to understand what insurance is, how to figure out what it is that the insurance companies are looking for when they're looking at their claims, as well as how to appeal and make it where they will actually pay for the things that you're asking for. Once my daughter was diagnosed, I actually went into ghostwriting appeal letters for those who were being denied with pumps and CGMs. And it kind of evolved into how to save people money, because that's the next big topic for people living with type 1 is how do I afford this? And I know Scott and Blue Circle Health do a great job with, on the backside, making sure that nobody falls through those holes. But we want to see what can we do to kind of preemptively get you into a better situation as you look at open enrollment. So this is my daughter when she was diagnosed. But some of the things that we'll be covering today are changes in healthcare, how to select new insurance, kind of what is it that you're looking for, this hot ticket items that are going to make it more apparent where you can save money or where you might run into a problem, how to understand your EOBs. These are explanation of benefits. That is something that the insurance company will send you once you've actually had something pay out. and just making sure you understand what it is you're looking at and how those costs are calculated. What are some of those top denial reasons? You might want to look at this and understand if you're looking at this, looking at the plan before you purchase it and what you might find on those summary of benefits or policies that might kind of tip you off that this could be a reason for denial later. And then also, what do you do when you're denied? How do you appeal? What kind of expectations are you looking at? As far as getting it approved or kind of looking at alternatives. So, some of the key things to look out for every single year, regardless of what's going on in the political world, are looking at out-of-state insurance. A lot of people, especially in the post-COVID world, are having employers who might be out of state. So if you are somebody whose employer is out of state and it's kind of a more generalized insurance, you want to make sure before you automatically sign up for that plan that you are finding doctors who are available in your network. Also, a lot of plans are turning into the biosimilar formularies and having somewhat of a limited choice. You need to decide for yourself, are you okay trying those? Are you going to want to fight it automatically? I will say that some of those biosimilars will be things that they'll want you to have kind of a step therapy. Try them before. Otherwise, you would want to make sure that you have a documented reason that you need to be on your other insulin plan or other medication. Are there any cost effectiveness limitations? These are more popular when you have self-funded plans. So say a big corporation, they might just be borrowing someone like United Healthcare to administer their plan, but that employer is going to have something called cost effectiveness, which is meaning if they can save $1, they're going to kind of say, okay, this might not be what we want to pay for as an organization and put a limitation on that. So we'll go into what are we looking at with those limitations and how to get around them. Another thing that they'll do with those types of plans is a carve out for diabetes supply. So they might say something isn't covered on a formulary on the pharmacy. It might have its own category, and you have to really analyze how is that getting paid for. Is it something considered DME? Is it something that its own category and it's got its own set of rules and regulations? It doesn't happen a lot, but it does happen enough to mention it. The other thing is about changing plans mid-year. I hear this a lot for people who are looking at, going from one plan to another. Maybe they switched jobs and they didn't get the COBRA. The deductibles do not carry over from plan to plan. You will have to start off on a new deductible for that new insurance or that new plan. Deductible versus premium pitfalls. We'll go into a lot more about what it means for saving money versus understanding what your risk is. A higher premium doesn't always make it more affordable. You have to kind of look at what your risk factors are and what you're comfortable with. So what do? You're going to make sure you are looking at the summary of benefits, but also if there's something you don't understand, you want before you pick the plan to try to get an answer, whether it's with your independent agent, a marketplace representative, or someone like Blue Circle Health who can walk you through it, or you're looking at talking to your HR manager, somebody who can get those or who's understands and is able to communicate that effectively so that you can pick the best coverage is very, very important. You also want to make sure when you're appealing that you are deciding when to fight. If you are looking at, say, a biosimilar and you're saying, I just don't like that they're switching my brand, but there's not a medical reason. You've never tried it. This doesn't mean that they're wrong. It just means that you might have to look at it as a whole picture. Is it worth fighting to have the name brand that you're loyal to simply because it's a name brand you recognize? Or is it because there is a medical reason that you shouldn't be on it? We want to talk to your employer well before open enrollment. The more you can get in front of your HR director, if you have problems, especially if it's a carryover problem from a previous year, if you're able to tell them ahead of time, this plan did not work well for your employees. This is the problem that we found with XYZ. Getting in front of them before open enrollment. Open enrollment means they've already made those decisions. They have already decided how that plan is structured. So if you're waiting until the plan is already activated for employees to pick, your chances of having any kind of insight or ability to get your thoughts to them have already rapidly shrunk. So you want to talk about plan exclusions, or if a rider is needed, especially with those big corporations, if they are doing things like cost effectiveness limitations, or they're excluding certain things. In the past, Omnipod was a hot topic for a lot of employers because it was considered a more expensive pump with the maintenance. However, employers are able to put into riders, meaning they can say for a self-funded plan, yes, we'll take UHC, but if the regular UHC plans won't allow this, we will allow it because we are the ones paying for it. But again, it has to be set up as soon as possible while they're making these decisions. Also, if you have an HSA or you have any kind of, they call it cafeteria plan, right? So these things that employers offer that allow you to put your pre-tax contributions in, you want to take advantage of those. If you are not, you're leaving money on the table because otherwise you're paying for things post-tax. And that could be anywhere from, say, 15% to 25%, whatever your tax rate is. I have a note in here. This isn't popular for a lot of people because a lot of people will not itemize their deductions on taxes. But if you are one of those people who are itemizing on their taxes, be aware that you will want to save receipts potentially. If you meet a certain threshold, and I put a percentage because it does change year to year with the federal tax agency, you are able to claim over that percentage. So say your percentage ends up being $7,000. So anything you spend over $7,000 could become a potential tax deduction. So that is something to talk to your CPA. If you have not already talked to them about this and you do itemize, definitely look at getting that conversation started with them. You want to analyze your plans for your premium, but also what is that deductible and coinsurance and your expected care for the year. That is the most important thing you can do when you're looking at choosing your insurance. What do you expect to happen? So every year, whether you're re-enrolling in the same plan you had or you're looking at new plans, you want to make sure that nothing has changed with your DME coverage, that the doctors are still in network. This is the number one thing that will change from year to year is doctors and hospitals. Those favorites that you might have might not be in that network anymore. You want to make sure that your outpatient services and ER costs and copays haven't changed, or that you know what they are. Same thing with hospital. This one's less needed, but you do want to have an awareness of what the options for independent and external appeals are, just so it's in the back of your brain in case that was needed. Is there step therapy requirement? So go ahead and look over that formulary for the plan ahead of time and see, are there asterisks? Are there like little things on there that make it where you're going, that doesn't seem very straightforward. That's one thing you'll want to highlight and have someone answer before you sign up. The RX coverage, another big one lately, the last couple of years, is combining deductibles with your medical side and your pharmaceutical side. When you have your pharmacy and your medical combined, it makes it troublesome to get started at the beginning of the year and having kind of like a positive cash flow going on because your HSA or your FSA might not be built out yet, right? You haven't necessarily made those contributions to those plans. Unless you're really forward thinking from the previous year on the HSA, but you are wanting to understand, can I afford this? If I had to start from zero at the beginning of the year and I have, say, a $4,000 deductible on the pharmacy side, Can I pay for my medications effectively if this is the case? Again, looking over, are they covering my items and at what tier? Am I okay with their alternatives? So again, that's a personal decision unless you have a medical situation that you have to take a specific medication. But knowing all of this as you choose, if you're on the border of one plan and another, that might be the thing that tips you over to preferring a different plan. So this is one of my favorite things to say. Why is it important to compare your plans yearly? I say, what is your time worth? If you are able to save yourself $2,000 a year and it takes you, say, 2 hours, I would say I'm worth $1,000 an hour. I think most of you would agree that, even a couple $100 an hour was worth it to you. So, what is your time worth? And people get into a very slippery slope of redundancy. This is every single year you're slogging through it. And then sometimes it's easier just to say, you know what, I don't have the time to do this, or, I don't understand this. So I'm just going to do whatever they think's best and move on. But you are leaving a lot of money potentially on the table. We went through a little bit of this earlier with making sure that your networks of doctors haven't changed or what other changes have been made. And then what are your choices? Employer, obviously, if you have an employer who offers any kind of health insurance, that's great. In most situations, that is likely going to be your best option if they're paying, especially for a portion of your premium. You have Cobra, which is when you leave your job. Cobra can kick in certain situations where you can pay for the full premium yourself and have that same insurance extended longer. You have your Medicaid, Medicare, and state administered plan options for certain people who do qualify. You have your individual marketplace plans, whether it's, going to be, a popular UHC plan, or maybe it might be a insurer that you've never heard of. You can add your entire family. You can add yourself as an individual. Say your husband's on a work plan, but that doesn't work for you. Let's look at putting the spouse on their own plan. That's an individual plan. And the best thing is child-only policies. So these are not subject to premium subsidies. However, it looks like those might be going the wayside anyway. So this will be more important for people to look at this coming year. Child-only policies are, say your employer isn't offering something at all, or it's not the best fit for someone who has a child with type 1. Child-only policies can allow you to choose the best plan for that child, which is often at a lower premium than what an adult would pay. If you've got a 45-year-old versus a 10-year-old, the premiums are going to be wildly different for that same plan. So it financially might not make sense to put the whole family on, say, a gold level plan. Maybe dad doesn't use as much insurance or mom doesn't use as much insurance, but the child is heavily saturated in the healthcare needs. You can put a child on their own plan and get them that plan that makes sense. And you guys save money by having your plan work for you and the child's plan work for them. I'll go over the pitfalls of that. So for non-insurance choices, there are a couple others I'll talk about briefly. They're not my favorite. There is healthcare sharing and ministries, as well as self-pay, of course, with the coupon cards and everything that are out there. But I do encourage people with type 1 to seriously consider ways to get on some kind of health insurance rather than be uninsured. Okay, so comparing new insurance options, you have premiums. So you have obviously your employer contribution if this is coming from your employer. They are required to pay a certain percentage of that plan. Generally, it's 50%. Some employers will pay more. For the most part, most are not going to be covering the family members of that employee as well. So you have to be aware that if you have, a $300 a month premium, that the spouse and the children will probably not be at that $300. They're going to be significantly more because they're paying full price on that. So again, that's where we go into potentially putting families on different plans. subsidies, like I said, this is going to be something to take into account as we look into open enrollment for this coming year. There is some potential that those are going away or drastically being reduced depending on how the courts and everybody votes. I'm not going to get into politics of it, but it is something to be aware that if those subsidies are not renewed, you will be looking at the full price on a marketplace plan. Um, and then, of course, you have self-pay. So when you're going into all of these considerations, you're looking at your premiums, but you're also looking at deductibles. Deductibles tend to rise, I feel like, every single year on the plans. People complain about how much the premiums are. So the insurance company says, okay, we'll stabilize that, but you're going to pay in turn more for your healthcare, whatever it is that you're using. We'll raise the coinsurance or we'll raise the deductible. So these are things to kind of keep in mind. It might look really good, but you have to look at how you use the plan on whether it works for you. Um, Same thing, coinsurance. I'll go into this in the next couple slides. Coinsurance is another thing that happens after the deductible. So you're looking at a deductible, but also coinsurance. If it's 0%, great. But sometimes it can be 40, 50% coinsurance. So those are kind of little red flags that you want to pay particular attention to make sure that you're not getting yourself into a situation unexpectedly because you weren't understanding what coinsurance is. Same thing with co-payments. I love a co-payment plan. If I see a co-payment plan versus, deductibles or co-insurance, that is going to catch my eye the quickest. Doesn't mean it's necessarily the best, but I am drawn more because there's a more predictable indicator of what your expenses will be because there's no question mark as to what the bill is. With deductibles and coinsurance, there's a big question mark. What is the ER visit going to cost? Or what is the hospitalization going to cost? What is the DME provider? The providers alone on DME can have different costs depending on who you go with. So there's always this big question mark, but co-payments, you eliminate that. So if you don't like surprises, co-payment plans or co-payment heavy plans will be your best bet. Out-of-pocket maximums, these are going to be kind of the like what is it going to be at the end of the day? Can I afford this out-of-pocket maximum? Is this going to financially ruin us? And what is the likelihood that I will get there? You also want to look at your RX deductible and tiers. So again, that RX deductible, is there a separate deductible? Is it combined or is there no deductible? So there's 3 categories that you're looking at with the RX or the pharmacy side. And then what tiers are you looking for? Sometimes there'll be an easy 3-tier. You're looking at generic, preferred and non-preferred, or they might be 5 tiers or 7 tiers. So it depends on how that insurance company sets up their formulary. But you do want to pay attention because ultimately those tiers impact what you're paying for that prescription each month. Okay, so let's go into understanding your responsibilities. So this is an idea of those things that we were just talking about. So say that hospital or ER does bill you $4,000. You're going, oh my gosh. Well, first of all, there is a benefit to having insurance is that there is a negotiated rate. So insurance has adjusted that amount down to $29.80. That means they've negotiated on your behalf. In this example, I have a $2,500 deductible, which unfortunately, that's a thing of the past. But if you can find one that low these days, that would be great. But you've got your $2,500 deductible here. So that is coming off the top. That is your responsibility before insurance even thinks about paying for anything on that plan. Left over, you've got a $480 balance. If you have a 30% coinsurance, that's $144. You're still owing that $2,500. So you would owe out of that adjusted amount of $2,980, $2,644, and the insurance will cover the rest. So just kind of a basic on how to do that. So with this, another example. So how are we reaching out-of-pocket maximum? What is out-of-pocket maximum? Out-of-pocket maximum is the most amount of money, either individually or as a family, that you will be expected to pay for your care and services when you are seeing in-network providers. So I'm going to use in-network providers as this example. If you go to somebody who is out of network, you open up a second potential maximum. So we're just going to stick with out-of-pocket maximum for those who are in-network. So under this plan, you have a $4,000 deductible in this scenario. If you had $5,000 of leftover supply at 30% coinsurance, you owe another $1,500, right? So you are looking then at 30% because we have a 30% coinsurance of $420. And the point is, when you're starting to add everything up, say you go to the ER and they're going to charge you 30%, which is $1,050. You don't actually end up owing that because at some point you've reached $6,600, whether that's, through your supply, or you had a hospitalization, or you have a large amount of pharmaceuticals to cover. Once you hit those out-of-pocket maximums, everything else is covered for the year if you're doing in-network providers, in-network pharmacies, et cetera. So I want to briefly touch on the supply carve-outs that we talked about before. These are what you're looking for in those policy guidelines. So here, buried amongst all of these papers, this was found. It is a pharmacy exclusion. Injectable drugs and diabetic insulin, diabetic supplies, and equipment are not covered under this section, but are covered under other sections of this contract. So if you see something like this, if you're trying to make those calculations on how much this is going to cost you out of pocket for the year, and kind of what might my costs look like, if you miss this, you might have an assumption that everything's covered in the pharmacy and plot out your plan for that year based on that. But then you find out it doesn't work like that. That could be devastating if that's not in that employee's favor. So having either your HR manager or your agent look for pitfalls like that is extremely important. I have a couple other examples there, but you can kind of see what I'm talking about. Okay, we're going to skip over this for a moment and go into, I'm just going to do a brief overview on dental because even though it is not necessarily medical or type 1 related, it is something that gets very confusing very fast for people because dental does not work the same as medical insurance. So I've put on a quick overview of what an EOB or explanation of benefits might look like from a dental provider. So you have your submitted charges, again, the negotiated rate. You have something that's not payable by the plan, and I'll explain that in a second. Amount remaining, what they pay at, plan benefit, and patient responsibility. So when you're looking at this, you're going, okay, this seems like a lot, right? It's plan benefits, $2,000. I owe $1,373. It seems like they don't pay a lot. But if you look at this plan, we have paid the maximum benefit allowed by the member's dental plan for this benefit year. All they were ever going to pay is $2,000. So if you have $2,000, that is the cap. That means they will not pay anything more. So the benefit of having dental insurance is you get whatever that plan benefit is, say it's $1,000, $1,500, $2,000, and you get the negotiated amount. Otherwise, they are not going to continue paying for the rest of the year. It is that cap. So if that was something that people did not realize when they were looking at their dental plans, the $1,000 is the $1,000. The $2,000 is the $2,000. Okay, let's go into insurance options. One thing that I really want to highlight is kids programs. I know this webinar is going to be for people across the country, so I'm going to give you an example of something that might be found in your state and something to look into. Not every state is going to carry it, but if your state does have this option, it is potentially one of the better options for children who have type 1 and the ability to save money. So, insurance in Florida, we have something called Kid Care, which allows members, any member, depending on whether you make, $100,000 or $500,000, it doesn't matter. If you are not Medicaid eligible, you can still buy into the Medicaid program using a funded amount. So you're basically paying a premium, which tends to be lower than a marketplace plan. And you're able to get all of the Medicaid deductibles or non-deductibles, their formulary, their network of doctors. So for this one, for $243 for that premium, you get $10 hospital visits, $5 prescriptions, $5 to see a specialist. I don't know of any other plan that has better ongoing monthly maintenance costs than something like that for a relatively affordable premium. So definitely, if this is an option in your state, definitely look into this if you haven't already. Young adults, insurance options. 26 is not always the cutoff for adults. I don't know. A lot of people have not been told this before, but I've listed out, you've got a handful of states who will allow you to continue on your parents' plan if you meet their rules and restrictions based on that state. So it might be, this one is a Florida example. They cannot be married. They cannot have a child of their own. They have to actually be in the state full-time or as a part-time student, and they cannot be under any other policy. If their parents' insurer is in that state, they should be following this. And if they're not, you need to have your parent have a talk with their HR department on why that hasn't been extended as an option. They will be expected to pay a full rate for it. If that employer is having some kind of subsidy when they're under 26 to lower that healthcare premium, that will not be eligible once they're 26, but there's a potential you're not kicked off your parents' plan. Okay, what to look out for as insurance for adults and children. So, one thing that I like to look out for, especially when you're looking at marketplace plans, is going to be things that have diabetes in the title, right? If it has a diabetes specific plan as the title of it, so for instance, Cigna Enhanced Diabetes Care Plan, you have these plans that are specifically set up in a way to make it as easy as possible for you to receive care as a type 1. They're going to cover, and this one needs to be updated because it obviously G7 has come out. However, this one included the Dexcom, it included the Libre, it included your strips, it included your insulin, it included all of those maintenance, your pump maintenance, your infusion sets, all of this at $0. $0 to pick up those prescriptions. So if you are looking at something, this again is going to be catching my eye, because if you like to know what your costs are going to be, something like this is going to be a big bullseye saying, pick me. You just have to make sure you're looking at that premium. Again, when you're looking at plans, I'm not telling you which plan to choose. I want you to be able to understand what it is you're looking for when you're researching these plans for yourself. So this one, I found, if I was a young adult or an adult or even a kid who was on a T-Slim or a Medtronic, and I don't anticipate having a lot of healthcare needs, I'm going to be looking at something like this, because if you look here, and your DME is covering your Tandem, your Medtronic, all of those tubed type pumps that typically come from a DME provider. Look at this right here. Scott, can you just verify, are they able to see my cursor? Perfect. Okay. So durable medical equipment, they charge $500 for a wheelchair, but otherwise all other is at no charge. That means it is not subjected to the deductible. It is not subjected to a coinsurance. portion, you are getting all of your pump supplies at $0. So if I didn't expect to have to go over here and spend $5,200 because I have a lot of healthcare needs and I go to the hospital a lot, or I'm really clumsy and I break bones, whatever that case is that might be driving those healthcare needs. If I just was like, you know what, I'm good. I just need my pump supplies and my insulin and all of this great stuff. I'm going to be seriously considering this plan because if it's got a larger deductible, chances are it's probably going to be less on the premium side. So you're kind of like hacking the system a little bit by this because you're going, okay, that's fine because this is what I'm looking at right here. And there's a condition care RX program with this insurer, meaning that condition care, and this was verified on the back pages, includes diabetes. And that means all of the prescriptions aren't $75, they're $38. So I already know I can get a reduced price on those. So I'm going to be like looking at this for sure as one of the plan options. Again, this one has a little bit of, you think it's going to be discrepancy. So I wanted to bring this to your attention. You have what seems scary. It says $3,000 pharmacy deductible, and you're going, oh my gosh, this one cannot work for me, right? But when you look at the actual pharmaceutical deductible information, it says that's on non-preferred brand drugs. So if you are on preferred brand drugs, you still have condition care RX at $35. Preferred brand is $200, but there is no deductible. The deductible, even though it looks like it up here, is only on non-preferred. So if you're going on the formulary ahead of time and you're seeing all of your items are listed as preferred drugs, this doesn't apply to you. It's this right here. So this would actually be fine because you're only paying $35 for those drugs. So, and again, this one could be saving you money because otherwise this looks pretty scary, and it might generally have a higher premium. So, okay. Again, what are your healthcare needs going to be? So take a look and be honest with yourself, be honest with your family. If you know you're going to need a hospitalization, don't start looking at bronze or copper plans. Do yourself a favor, look at silver or gold, because if you are definitively having that, you want to avoid those heavy out of pocket maximums. And we touched on this before, separate your family. If you need to separate your family, I will tell you, my husband has a work plan. If he added me to his work plan, it is $900 for me to go on his work plan that has a $3,000 starting deductible, including for drugs. He doesn't use a lot of healthcare, so that works for him. He enjoys the reduced premiums. But for me, I'm a heavier user of the healthcare side. I cannot do a large deductible like that on top of the insult of paying $900 a month to do so. Then on top of that, I have two children, one with type 1 and the other one who is not a healthcare heavy user. What did I do? This is how I saved our family thousands of dollars. I don't accept $900 a month for me to be on my husband's plan. I went on the marketplace, and because my husband is offered insurance, I was not eligible for a subsidy, which is fine because I am still able to pay $500 a month for my plan. And I was able to choose a plan that works within what I need it to do, whether it's the deductible or specialist or co-insurance, et cetera. On my children, we talked about that Medicaid buy-in. My daughter, if you didn't figure it out yet, my daughter is on the Medicaid program in the state of Florida. Both of my children are, because it was within $100 a month to add them to my husband's plan as dependents. However, I would have been subjected to the thousands and thousands of dollars deductible for each child. If I spent a little bit more on their premium per month, I saved myself the potential of thousands of dollars, knowing my type 1 is going to need that healthcare, the DME or the pharmacy side. So it really saved a lot of money by separating out the family. The only pitfall is the family out of pocket maximum will not be combined together. So if you have people in your family, say you've got 4 family members and 3 of them are constantly in the hospital, that might not be the best situation. I'll show you in a moment how to look at that for yourself and decide if that financially is the best way for you. But that's generally the only pitfall of splitting up the family is the family out of pocket max is separated, but most people will not need to hit that family out of pocket maximum because it takes a lot of, you have to have at least 3 family members hitting those out of pocket maximums in order to kind of start to justify that family out of pocket maximum. Again, I talked about talking to your HR department, but also just for yourself. If you are looking at open enrollment for your company or your husband's company, I would always double check what you're looking at healthcare wise. So as soon as that open enrollment starts in the marketplace plans, just do a look and see if a marketplace plan might work better, especially if you're looking at splitting it up. But the more you can start building out that information ahead of time, the better. The pitfall is for those employers who are going into their plans mid-year. I really dislike having mid-year shifts and insurance plans, the ones that start July 1st or September 1st. I really feel that's a disservice to the people who are potentially needing to look at alternatives. But for the most part, most companies will have their open enrollment start in October or November, depending on the employer. And then, of course, Marketplace opens in November. They are shortening the amount of time this year for open enrollment in the Marketplace. So keeping that in mind, December 15th, as of right now, is the cutoff. They were extending it to January 15th. That has been shortened back down to December 15th, where it was years ago. We went through this briefly with dental, so I'm not going to spend a lot of time on this, but what I want to point out is see these remark codes when you're looking at the explanation of benefits. You always want to just double check that they're aligning and that things aren't needed. So for instance, this one, you've got 2, it says claim under review. So it says you owe 0, but then also nothing's been paid. So you want to make sure this is something you're following up on so that there's no surprise later if it doesn't get billed and then you start getting bills from that provider. So you want to make sure they're submitting their paperwork on time. They've only got a certain amount of time to send that back to their insurance company. Make sure you stay on top of them if something is needed. Top denial reason. So again, what we just talked about, insufficient documentation. The doctor or provider didn't send enough information. That one's a fairly easy fix. They just take that information and send it right back. Medical necessity not proven or investigational or experimental. These are things that are not insurmountable to overcome. They just take a little bit more on the back end to prove. So you've got to look at maybe a research study or get your doctor involved on establishing the series of steps that it got to where it needed to be to provide care. So if they say, okay, medical necessity not proven, but maybe the doctor left out that they did X, Y, Z, it wasn't thoroughly documented. All they have to do is improve on those notes and establish that can be overcome. Not covered by plan, or it's considered over the counter is another reason for denial. The cost effectiveness clause or step therapy, meaning they want you to try something else before they'll approve this. Sometimes the doctor just sends the wrong codes in. So that one's an easy fix, but you have to be on top of it. It is a plan issue. So say the doctor went out of network and you didn't know and you saw them and nobody told you, but now you get the surprise, hey, they're not in network. Or the bill didn't, your auto pay somehow didn't go through and you had a policy lapse. These are all things that can cause issues with denial if you're using those healthcare services during those periods. And then, of course, what they consider to not be an emergency. This one's my favorite. I not really, but they'll say, okay, we saw this person at the hospital, but it wasn't really an emergency. Like, we are supposed to know this ahead of time. We are the mini doctors who know whether something is truly an emergency or not. Um, so managing expectations, you have to be realistic, assess the severity of the issue as a whole. Are you looking at a $40, issue? Or are you looking at a $4,000 issue? Um, don't be afraid to ask for help, including from your doctor's office and your hospital admin teams. A lot of times, the more you can put them on notice, they'll be able to either help you out to begin with or be aware of the situation if it doesn't work out and the appeal doesn't work, that they can work on getting some kind of payment or cost reduction for you on the backside. You will get back what you put into it. If you have a paragraph as your appeal and you don't assess whether you're talking about your medical needs and your medical reasons, in basically their terminology, you're saying, okay, I want a Dexcom because my child deserves it, or my child's young, but you don't go into the reasons why it's important for a young child, or I lost my job and this is so expensive. And I really, the sob stories. You have to look at it as a business. You have to identify the reasons why it might be denied, including going into the back pages and doing the Google research into, okay, what are their policy guidelines? Are they available to the public? I would say 8 times out of 10, I can find that policy guideline on why they made that decision and be able to fight it more effectively because I know why it was denied based on their own policy. So if I see something as a reason, whether it's the Dexcom was denied because the child is, not or well, I'll say a pump. A pump wasn't approved because the child wasn't diagnosed at least 6 months. That's a very popular one. You can say, okay, I can see here, and now I know all of the reasons to put in my appeal letter on why it's important for a child who is newly diagnosed to have a pump, including, fear of needles or the smaller ability, the ability to do micro doses on a pump that you can't do with a syringe, or maybe it's, they are grazing throughout the day. So they, don't have, you know, a couple shots for meals. Maybe they have, a dozen shots for meals needed. So all of those things you formulate into a plan on what it is they're denying, but how to counteract that. This one I hear a lot. Unfortunately, out of pocket costs do not mean it was denied. It just means that is your responsibility based on the plan that you selected and that they are implementing. Also, you want to look at the time restrictions. If you sit on it because you're terrified of, contacting the doctor or asking for help, and, you let 6 months go by or whatever it is that they have a time restriction on, if you get beyond a certain window, there is no appeal ability because you've surpassed the time allotment. Again, what to do? You have to look for the denial letter. They always have to issue you a denial if they're denying. So that is going to be giving you that insight into, what is it that they're denying and why are they denying it, as well as who denied it. So sometimes that becomes important. Is this somebody who is a professional in that field? Are they an endocrinologist or are they an orthopedic doctor who just denied something? So how likely is it that they even understood what the service is that they are denying? Because that can be used in the appeal later. If something is denied, can you flip it? Is this something available on the pharmacy side if they were denied on the DME side? Or if it's denied on the pharmacy side, can you flip it over to DME? So always look, is there an alternative on my plan that can still get this paid in some manner? And is this something that can be gained through a different avenue without an appeal? Some sometimes you have to look at alternatives. So it might be that there's a resource out there that is available and, you need it more immediately and somebody else can provide it quicker than you going through a 30-day or 60-day appeal process. Um, so let's look. We were talking earlier about HR departments and those writers. So if your plan starts and you find the self-funded plan has this limitation or it's not paying for something, definitely go to your HR department because some companies have the ability to do an override or a rider that will change that and get that bill paid. So definitely ask them for that. There's nothing to lose by going to HR if you're on a company plan. Um, Peer-to-peer review, if your doctor is able and willing, I definitely say this is the quickest option. If you get your doctor involved, there is a 24-hour timeline for that turnaround versus a 30-day timeline. And sometimes it's just a matter of them having a conversation with that other insurance's doctor that you can't do, but your doctor can. So they might say, listen, bro, what are you doing? This is why they need it. And they say, oh, you know what? I didn't think about that, or I didn't consider that. Let's go ahead and approve it. Great, done. Move on to the next person. So if you don't have the time to appeal yourself, call the doctor for a letter of medical necessity and kind of use that to build into an appeal. Or sometimes they will appeal for you. So if they're willing, obviously that would be great. Not everybody's willing. You might need to get medical records or logs depending on the severity. Again, a $40 bill or denial is not going to be the same as if a hospitalization was denied and it's $10,000. You better believe if that hospitalization is denied, you want all of the list of charges and medical records so you can go through that with a fine-tooth comb and figure out what might be able to get that overturned. We talked about this already. See what professional organizations and groups are out there. There are websites now that will generate appeal letters for people. It's crazy and they're free. So it's fantastic resources out there, but you have to know that they're out there. Are they in violation of any state or federal laws? That's always a question mark because most states do have some kind of mandates for coverage for diabetes care and for the people who live in that state. So are they completely in compliance? And then I like to aim for 2 to 5 reasons. 2 to 5 per denial reason. So if I have something saying, they're under 2, right? I'm going to try to find research studies, at least 2 of them that say, we have these research studies that show that under 2 were successful. And I'm going to use that as an example to counteract directly what that denial reason was. You want to be professional. Again, you don't want to sit there and talk about how, Bobby Joe lost their job and, everything's a mess. You want to make sure you're almost like guessing. They're having to guess who wrote it. Was it an attorney? Was it a doctor? Was it the member? Who wrote this? Because if it's of that level, they are going to take it more critically as far as, okay, they understand what it is they're talking about, and they're going to pay more attention to the reasons you're saying as fact rather than looking at it as everything's personal. And if they're not empathetic, if they're not sympathetic, they're not going to go out of their way to make their company, their employer, go through an extra expense that they can't justify according to their policy guidelines. So it has to be something that they feel like they could justify. If their boss came to them and said, why did you approve this? Well, they said in this letter, this, and this, and it was fact-based. It wasn't emotionally based. Therefore, they don't lose their job. Everybody's happy. So again, watch your tone. Bullet points, the easier it is for someone to read. If there's something important, If there's something important, address it first. The longer it is, the less likely they're going to read. So if your important point is at the bottom, bump it to the top. I'm going to just kind of briefly go through this because we are running out of time. And this is the main thing I want to cover as we close. So let's go into comparing plans. Comparing plans, this is how you're going to save your money. I did have one typo here, so I want to make sure I point that out, that the math wasn't mathing. I had a typo there. But if you have Excel or Google Sheets or something, and you're trying to figure out what it is, what am I looking at cost-wise? You can develop an easy Excel spreadsheet that has these categories that you see along the side, as well as 2 scenario options. So if you're, and I'm assuming type 1 is your only medical need. If you have additional, you would want to kind of build this out to be your specific situation. But you want to have this on one side, and then you might have more than 3 plans. You might have 7 plans that you're trying to figure out what might work best. But it gives you an idea of what your premium is. So you just fill this in. This is all going to be information available when you're looking at a summary of benefits, or you're talking to HR, or you're talking to your agent. So you go down the list and you fill it out according to this. You're going to calculate what are your premiums per year for each one of those plans. And then what is the likelihood that I will need the service? With type 1, we know you're using services. There's no avoiding using services, right? So in a good year, you might be going to a specialist 4 times a year. You're filling, 3 prescriptions. You might be filling, your insulin, your test strips, your Lancets, because everybody fills those every month, right? But generally, there's going to be about 3 prescriptions that you'll be picking up. And you're doing that every single month. Then you say you are on a Dexcom and a Tandem, and that's a DME product that doesn't have a $0 fee. And you're having to pay that on the DME side. What are we looking at? But what if you have all that and you end up in the hospital? So you want to look at kind of what is a bad year look like for you. So a good year, that's your maintenance year. Your bad year is, you really had it rough and you're going to use those healthcare services. So let's go plan 1 and use this as an example. $240 right here is because we're looking at 4 specialist visits. So 4 specialist visits, we're doing 60 times 4, 240. Then we're looking at 3 RXs over the course of 12 months. If you were to take 36 prescriptions and times them by $20 a piece, you're looking at $720. If you are on that plan that has DME at $0, guess what? There's no fee right there. So your good year is $960 on this most expensive premium plan that we're looking at. But what if you were in the hospital? You still have all of this, but then you go to the hospital and say you're there for the 2 days here. So it's $600 a day. So I'm having to add in another $1,200. So that brings me for that bad year to $2,160. But you still have to consider your premiums. Your premiums are going to be good year plus premiums, $93.36. Bad year plus premium, $10,536. So it's very, very similar. There's not a big gap between these, which means it's a pretty flat-lined plan. You're going to spend a lot regardless of whether you have something bad happen to you or not. But if something bad does happen, you're not going to spend that much more. Then you look at, okay, I couldn't really afford that premium every month. Let me look at some lower prices. Okay. So we're looking at $535 here. So we'll get back down. We have a 62 or 60. This is how I get my numbers mixed up later. 6,420 for the year. So $300 because we've got a specialist copay of $75. Plus you've got $2,160 because it's not $20 for this plan. It's $60 for those 36 prescriptions. And so you're looking at still the $0 DME on that plan, and you're at $2,460. But, like we talked about, some things happen. This one is a copay plan in that the hospital for inpatient is $3,000 a day copay up to $6,000. So basically the first 2 days are $3,000 a day. And then everything over that, they're not charging you $3,000 every single day. It's just capped at 6,000. So here we have it, 6,000. So you're adding all of that together, 8,460, which is going to be under your out-of-pocket maximum. So when you're adding in your good year premium and your bad year plus premium, good year is 8,880. A bad year though goes up to 14,880. So now you have a comparison. Okay, I'm going to save about $500 here, but worst case, I'm looking about $4,000 here. Let's continue to look. Wow, this one looks really great. It's $450, right? Oh no, this one does have a deductible and a coinsurance, which are new factors that I didn't have to look at the last plan. So we're going down here. This premium looks a lot better, $5,400, but you're looking at $320 because you have a higher specialist copay, $2,000. So these, I'll do the math really quick for you. 2,000 is you've got a deductible here. So when I started calculating the right here, this deductible is combined. So I had to use that up to get those RXs right there and to utilize that Tandem and Dexcom DME benefit, which is deductible and coinsurance. So I already know I'm hitting $2,000 for sure. You are definitely going to go over that. And then once you start, you can either calculate it from the prescription side and then go into DME, or the DME side and then go into the prescriptions. But if you're looking at it, you're looking at it a 10% coinsurance. So whatever, after you have your $9,000 and you've got your 3 times 12 prescriptions, so 36 prescriptions, and it's still a $40 per prescription item, you're still looking at, over $1,000 right there. So put those all together. I put the 40, you know what? I still ended up doing that wrong, didn't I? It's supposed to be 4,460. I just repeated the exact same thing as I was trying to update this. So if you add everything together, it's 4,460. So a bad year, same scenario. You've got the 320, you've got the 2,000, you've got the 1,200, and you've got the $900, but you went in the hospital. So it's the same scenario. You have a $6,000 copay. However, if you add all of this up, you have now exceeded $8,700. So that is your cap. It has now kicked in. You are not going over $8,700. You still have your premiums, but you will not have any more healthcare expenses for that year. So if we add those together, your premium for the good year, let's add $40 to that since we know it was needing to go up. So it's $9,860 or $14,100. And it doesn't matter that my math was off because we hit our out-of-pocket maximum. So here you see that this plan ends up being, in a worst case scenario, better than plan 2, but it's a little bit more expensive for a maintenance year. So if you're looking here to here, it's about $500. Here to here, it's about $1,000. Here to here, it's $500. But here to here, it's a big gap. So if you are looking at saving money, and I have a suspicion that I will not need any hospital visits whatsoever. I'm pretty comfortable in the fact that I have never been in the hospital. I can almost assure you that I'm not going to the hospital. I would be looking at this one because $500 is $500. And as long as I'm willing to take the risk of going to the hospital, I could save $500 here. If I'm like, you know what, I really hate the potential of going in the hospital, I don't want to risk it, or I know I'm going in the hospital, I'm picking plan 1 because I know that worst case, I'm looking at, well, I shouldn't say worst because we didn't hit our out-of-pocket maximum there, but it's more likely that I'm going to be saving money in a bad year versus plan 2 or plan 3. And then plan 3, you say, okay, $9,800 for a maintenance year, it looks great, but you know what? I'm spending more money than I need to. So if I'm spending more money, is this really worth the $450 if it's going to cost me more than this plan later on or this plan later on? Maybe this isn't the plan, especially since it's still, pretty big gap between this plan. So you have to look at all of these things, and maybe what you started thinking at the beginning of your research isn't what you find to be the best fit for you. Um, but if you're not doing this every single year, you're leaving money on the table. So just wanted to point that out. I do have this. I do need to correct this, Scott. So I'll work on getting that corrected so we could have that as a principle for them. But the plan is based on a Google sheet or Excel. You can keep that every single year and just update it as you go. So really, the first year will take the most time. And then after that, it will just fly through it. And within an hour or two, you could be saving hundreds or thousands of dollars. Scott, I'm going to turn it over to you. I know I've touched on a lot of information, but hopefully I've answered some of the questions that might have come in. So, is there any questions you want to ask?
Oh, this was fantastic. Thank you so much. When we first started talking about this, I fall into the category of like, I'm just going to pick the most expensive plan because I assume it's going to cover the most. And this was really helpful in drilling into some of those nuances that can save us some money. So, we do have a couple of questions. How are you doing on time? Can we spend 5 minutes? Okay,
Absolutely.
wonderful. Um, so I'm going to just kind of bounce around in the questions as they came in, which is great. And thank you all for asking the questions. Regarding the printable sheet, I will get an updated copy sent out with the recording as well. Um, so a question on, you talked about the Medicare, Medicaid buy-in. Does your family income need to be under a certain amount for your kids to be eligible for a Medicaid plan, or how does that work?
So this would be a Medicaid buy-in, which means that it is not subject to typical Medicare guidelines. Because if you qualify for Medicare or Medicaid in your state, that you're strictly on the Medicare or Medicaid plan. However, if they do allow a buy-in, and I can't speak for every state, but typically you are buying in on that premium and there is not a cap. For instance, in Florida, there is not a cap. There is a sliding scale option for those people who might be over Medicaid eligibility, but under a predetermined threshold. So say it's $80,000 and you might only pay $20 a month for your premium in that regard. However, if you're over, say, that $80,000, and it changes year to year, but if you make $500,000, you still only pay the $243. There is no income cap for that particular state's plan. So it is going to be subjective to the state, and not every state has a Medicaid buy-in. But if it is an option, generally it is a true buy-in and it's not necessarily subjected to those. But hopefully you find that in your state it is eligible for a buy-in program.
Yeah, that's a fantastic tip. I didn't even know there was such a thing, and I would bet a lot of our viewers also didn't know. Next question is around the appeal time windows.
Yes.
Where do you typically find that information? Is it something you have to call in for, or is it published in their document somewhere?
So typically it's actually provided with the explanation of benefits. So with every explanation of benefits, there'll generally be a disclaimer of some sort on what your appeal rights are and where to send the appeals to. So within that, it will give you typically a established timeline. Appeals are due within XYZ time. This is our turnaround time. This is the number to call if you have any questions. It gives you the protocols on how to accomplish that. If you're not seeing that on your EOB, say it's on the website and you never got a physical form, and so it's cropped out, there will always be something on your healthcare plan's website explaining appeal options, and they will need to say what the timeline is, whether it's 6 months or 3 months. Every plan is different, but You want to pay particular attention, especially if you think, you've got 6 months and it's not a big deal. But when you have a doctor's office potentially taking forever to get something back, or you're waiting on records, that time goes really quickly, especially if you're not on top of it and actively thinking about it every single day. It might be a month and you're like, oh man, I forgot to call, or a lot of times they'll say, okay, we put the notes in, somebody will contact you in 2 weeks. And then you're waiting on that call and they never call. And then you got to track someone down. And then that's another 2 weeks because the first person didn't do it correctly. So it eats up that time very quickly. And once the time is done, it's done. There is no going back.
Yeah. Okay. That's very helpful. Um, you touched a little bit on pl- finding plans for children. And one of the questions is, how do you find plans for children? And I'm wondering, I know you live in Florida, your annual conference is in Florida, so a lot of what you know is very Florida based, but are there some general search terms, or like how would you go about this, both in Florida and if you were in another state?
So it's actually any plan on the marketplace can be a child only policy, unless there is some kind of exclusion specific for that insurance company. If you are on the marketplace, you are going to be shopping as though you are looking for your child. So, whatever, when you go onto a marketplace, for instance, and you put in that you are, it'll ask you for your age. You might just say it's just you, meaning the child. So I am, Madeline, for instance, and I am 11 years old. Here's my birthday. I'm not a smoker. I'm the only one looking for a plan. It will pull up the plans that they are eligible to potentially choose from. And if that is something, you're not going to put in your income verification portion because, again, there's no subsidies for these, but you can shop as though you are your child. And whatever you see is an option. So you just have to whittle it down based on what your, healthcare needs are and what we just talked about. But that's the easiest way.
Yeah, I love that. Okay, we've got like three more questions. Are you still okay time wise? I want to be, I really appreciate you diving so deep with us on this. Um, Is it possible to have dual insurance? Like, say, if both spouses are working, can they both sign up for family plans on both of their employers? And is there a benefit there?
So yes, you can. However, it's not my favorite.
Mm.
How, and I say that because typically, unless the employer is heavily subsidizing, you are now paying premiums for two different plans. If you're paying premiums for two different plans, I would probably say you're not making necessarily the best financial choice because you're automatically doubling your premiums, which, as we looked at this example, can be quite costly. You're having to worry about getting the doctors who are in both networks. You are having to worry about the formularies matching, which 9 times out of 10, there's some discrepancy somewhere on what is on that formulary. You are having to do two sets of EOBs. So the first one will go, you wait, then the second one goes. So if there's a problem, you're catching it much further on in the process than what it is with a single insurance. And the ultimate thought is yes, it can save you money, but it's so convoluted to get to that point. It's usually easier just to put them on their own plan on a marketplace. There is something called the birthday rule. So it's not even that you get to choose who they're using first as that first employer plan. It's going to be whatever parent has the birthday earlier in the year. So if your husband has a worse plan, but his birthday's in March, and you have the better plan, but your birthday's in September, they're going to start with your husband's plan and then go to you. It doesn't work in reverse.
Interesting. Okay, that's great to know. Um, how can we actually get all of these details on the plans before actually signing up? It often feels a little difficult to get our hands on these policy documents until we're a member.
Yes, I agree. So that is probably the toughest part and the most frustrating part. So what I recommend is trying to get as far into the process as you can based on what you are able to see. So it is going to be the things that are easily seen on a summary of benefits. You have to dig a little bit deeper to get that DME. I will say most summary of benefits will not show a durable medical equipment portion. You have to usually go into the policy documents to get that, or contact the agent and have them tell you what that's going to be. Um, Once you've kind of narrowed it down, I would say to the top two, then you would ask your HR person or the agent that you're working with. And even though it might be Marketplace, there are agents who are working for Marketplace who are able to get this information for you. Ask them for the full policy guidelines or the full policy documents before you sign up. So they'll email them to you and then you can pick it apart. I wouldn't do it with 7 plans, but if I'm really strongly considering one or two, I would do it for those top two for sure.
Yeah, great. That makes sense. All right, last question we have on our list for today. But I love that we have so many questions. This is clearly a hot topic. If there are words or things, topics in those plan documents that I just don't understand, it's using lingo I'm not familiar with. Where's the best place to turn? Would that be like my HR benefits manager? Would it be someone at the insurance company who it's like luck of the draw, whether you get someone good on the phone or not? What are your thoughts there?
So I would say that HR will generally, when they sign up for plans, they are actually working with an agency of their own. So they have the ability to ask an insurance agent who is trained on all of these, and because that's what they sell, they have to know what they're talking about. They can usually either ask on your behalf or put you in touch directly with that agency. So if it's work, I wouldn't necessarily trust the HR person. If you're asking really in depth and you're not sure if they're quite understanding or something's not making sense or it's contradicting what it is that you're seeing on the paperwork, ask to have that spoken with the insurance agent instead. Same thing with Marketplace. The Marketplace people are trained. And generally, there's levels. If they don't know something, they're able to get that answered for you. So again, insurance agents, they are there to explain all of this for you. In before you make this decision, they're getting a commission generally on this. So it is in their best interest to make sure that you are getting the plan and understand your plan so that you're not negatively reviewing them or, making a complaint against them that they were sold something that was inaccurate.
Great. That's very helpful. Thank you. All right. So that's all the questions that we have. Thank you, Samantha, for taking us through all of that information. It's definitely an overwhelming topic. You made it feel easier to understand. It's still very complicated. There's a lot of nuances, but very, very helpful. So thank you very much for that. Um, I'm going to put your email address up on the screen. Are we brave enough to do that? Are you comfortable with that?
Absolutely.
All right. There we go. Now we got all of us. Yeah, just thank you again for that. I know you spent a little extra time with us, and I really appreciate that. So thank you very much. And I will go ahead and let you drop off, Samantha. I'm going to stick around to kind of close things down and also do that Blue Circle Health explainer for anyone who's interested and would like to learn more about that. But just thank you so much for helping us with that. A lot of great feedback in the chat and the comments. So we really appreciate it.
You're welcome, Scott. Thanks so much for having me on.
Of course. Thank you.
Bye-bye.
All right. So, want to share some upcoming community events. So, this slide has a few things that have already happened. So, for example, our cooking class happened last Monday, but it was fantastic. And you can find the replay of that on our website, bluecirclehealth.org/events. The navigating insurance is where you are today. And then next week at this same time, same day, so Tuesday the 23rd, we are going to bring in Diatribe to do an intro to Diatribe and the Time in Range Coalition. You can find some more information on all of these at bluecirclehealth.org/events, and you can also register there for anything that you might be interested in. And then we've also got the monthly group sessions in both English and Spanish. The English sessions happen on Thursday and Friday, October 2nd and 3rd, with the Spanish session on October 9th. So keep an eye out for those details. And just a friendly reminder that those group sessions are only open to past and current Blue Circle Health program participants. So again, check out our website events page for more information and to register. That's bluecirclehealth.org/events. And then finally, please do share your feedback. So depending on how you joined, you may see a survey once you close out of the window that you're in. I'll also include it in the follow-up email. We'd love to know if this was helpful for you and what other topics you'd like us to cover. All right. Again, for anyone who is here today who may not be familiar with Blue Circle Health, I'd be happy to share a quick 5-minute-ish overview and then stick around to answer any questions. I'm going to go ahead and start slides here. All right. So Blue Circle Health offers free add-on clinical care, education, and support for people with type 1 diabetes. We're a 501c3 nonprofit organization funded by the Helmsley Charitable Trust that works alongside diabetes care teams to support people with type 1 diabetes and extend the care that they already receive. Our mission is to learn the best ways to care for people living with type 1 diabetes, to apply those learnings to care for as many people as possible, and then share our learnings to improve type 1 diabetes care everywhere. So, what exactly does that mean? We offer a free, flexible program to extend care between visits. Our program is up to 6 months long. It's done entirely virtually over Zoom, text, and phone. It offers as much or as little support as requested, so you can take advantage of every service we offer or just pick the ones that you need. And more on that in a second. You stay connected to your medical homes, and we send them regular updates throughout the program. Our services are free regardless of insurance and immigration status, and re-enrollment is possible 1 year from the original enrollment date. Now, the graphic on the right shows all of the available services, and I'll describe them in more detail going counterclockwise and starting with clinical care. Clinical care, it's exactly what it sounds like. It's visits with an endocrinologist or advanced nurse practitioner. Next is insurance navigation, which is consultation with insurance specialists who can help you understand and maximize any insurance coverage you may have, help you find insurance coverage if needed, and also help with prior authorizations. So all of that deep in the weeds insurance information that we covered with Samantha today, we have a team of people who specialize just on that world of insurance and can help you decipher some of the things that may be just confusing or hard to understand and really just help you make the most of any coverage that you may have. Diabetes supportive counseling offers help with the emotional burden of T1D. Case management, we have case managers who can help if you're struggling with food, housing, or employment insecurities. Then we have peer support and community. So in addition to the monthly group sessions that I mentioned, you'll have a dedicated T1D support guide to work with who will help you navigate all of the other services and just be there for you if you just need someone to talk with. And then we have ongoing community events just like this, as well as connections to other great type 1 diabetes community organizations. Education and nutrition is visits with registered dietitians and certified diabetes care and education specialists. Then there are 2 additional programs available within the Blue Circle Health overall program. The first is a prescription assistance program for qualified applicants who need help paying for supplies and medications. The qualification for that program is an income level at or below 300% of the federal poverty level. And then we have an Intro to CGM program, which provides 3 months of free education and access to a CGM for those who have not had reliable access to one before. When it comes to eligibility requirements, they are as follows: diagnosis of type 1 diabetes. And no, this does not just apply to newly diagnosed. We're here for you anywhere along your T1D journey. And yes, this also does include LADA. You have to be an adult, so age 18 or over, English and or Spanish speaking. You have to have an ability to connect and participate in virtual care, which means access to a smartphone or computer for Zoom video calls. You must have a primary care provider or endo, or be willing to be connected to one. No current pregnancy. And then you must reside in one of the states that we're available in. Today, that is Alabama, Delaware, Florida, Iowa, Louisiana, Maine, Mississippi, Missouri, New Hampshire, Ohio, or Vermont. And that list of states is always growing. So please check our websites and follow us on social media for the latest, especially for those of you who might be watching this recording after the fact. Again, here's a list of the states that we're available in today. We're grateful to have had the opportunity to help over 750 people with type 1 diabetes since January 24. And I actually think the number I have on this screen, it's a little bit dated. I think we're up to over 850 participants so far. But that number is also constantly growing as well. I'd like to play a short video from a few of the people who have gone through the program. It's about 2 to 3 minutes long. And while that's playing, if you have any questions, go ahead and share them in the chat, and I'm happy to stick around and answer them.
When I explain it to people, I usually say, living with type 1 diabetes is pretty burdensome, complicated. It's really, really tough, challenging, too many ups and downs. I'm never not thinking about it. I lose a lot of sleep. It's very emotional. The only predictable thing about type 1 diabetes is that it's unpredictable.
It makes me feel really vulnerable and afraid. And I don't like feeling afraid and vulnerable with my diabetes.
My daughter was diagnosed when she was 3. If I couldn't afford for both of us to get supplies, and I'll just literally take the shirt off my back, take the insulin out of my body and put it to her.
Like, it's a battle every day. And insurance shouldn't be such a fight.
I literally spend days on the phone calling the provider, calling the pharmacist, calling the insurance, calling the pre-op company, and then calling all those people again to tell each other what the other one said.
It's like everyone's pointing their fingers at someone else. In the meantime, I'm watching my supplies dwindle away to nothing.
Like, that's a constant fear, And so things that feel like a fundamental right are out of reach for many people.
It's just wrong.
A friend of mine on Instagram sent me Blue Circle Health, so I immediately signed up.
Blue Circle Health is a nonprofit with a free clinical care, education, and support program. We deliver our program entirely virtually. It's all telehealth, and it's up to 6 months long.
You get education, you get support, you get assistance navigating insurance. It's phenomenal.
I don't know where I would be right now if I didn't find Blue Circle Health. They picked me up when I was at one of my lowest points.
It's just honestly a godsend.
Felt like they get it. It felt like we're making the change that we should already have. We were really fortunate to have funding from the Helmsley Charitable Trust to make this possible and create this program and be able to offer it for free. My life has drastically improved. I have really great insurance. The insurance counselor through Blue Circle was amazing. Not much makes me that emotional, but having to not worry about the financial aspect of that as a single mom who's rebuilding is, it's really comforting. Yeah, I'm crying. And if Blue Circle Health can get out there and show people that this is the right way, it's the right thing to do. You don't have to go through it alone.
All right. Thanks so much. And thanks for the great questions. Gabby, I will work on trying to get someone like Samantha, who is a native Spanish speaker, to deliver a webinar just like this in Spanish. In the meantime, I'll work on some translations, but I know that those are a poor replacement for native language. So that is all that we have today. Thank you all for your time and attention. I know that we ran over, but I hope it was worth it. If you do have questions, please visit our website at bluecirclehealth.org to learn more and sign up. And just please also stay tuned to our social media channels for announcements of more upcoming webinars. All right. Thank you so much, everybody.